Good evening, everybody. I think already we are nearly half a century of people into this session. So we'll just wait for maybe another 60 seconds to 90 seconds before we start. It's a pleasure and privilege to have everybody in. And I can already see that there are quite a few of the people for whom it is intended for. Essentially, it's all started with the students of Apollo Gleneagles Hospitals, Kolkata, the DNB trainees at Apollo. But yeah, I think over the last couple of months, it has expanded, and we find that from the friends of the students that we have, it has reached to a lot more people. So I think we will quickly run through this, which is preoperative pulmonary evaluation and optimization. We went through the facets through which you can go through it. So what we will try and do is run through this. So you see, the reason you need to evaluate for risks and figure out whether this person is going to safely go through this journey of surgery is to figure, because of this high perioperative morbidity and mortality coming from respiratory complications, which is why we need to evaluate. What we will try and do over, I know it is already 9 o'clock. Maybe we should finish within 9:30, max 9:40. Is define postoperative pulmonary complications, understand the pertinent anesthetic physiology, identification of patient and procedure-related risk factors, and the role of preoperative pulmonary testing, which has mainly been dealt with by Dr. Polash. Strategies for optimization, which will also be kind of an overlap with the third point, which is identification of the risk factors, and that is those risk factors, how it can be optimized. Okay, there's been a huge kind of a difference about what exactly is the amount of pulmonary complication. Some people have been over enthusiastic saying that up to 70%, but this is because of a lack of a proper definition. The definition which has been given, I think this is one of the best definition to go through by Dono, that what is postoperative pulmonary complication is a pulmonary abnormality which is appearing in the postoperative period, which produces identifiable disease. You can identify, or a dysfunction in the pathophysiology, which is clinically significant and is definitely adversing the clinical course. So you identified a pulmonary problem, clinically significant, affecting a clinical course. This is the definition. And going by this definition, what are the things that causes this are just a very wide spectrum term, like an atelectasis, infections like bronchitis, pneumonia, respiratory failure, which is defined by necessity of mechanical ventilation for more than 48 hours post-surgery, or an unplanned reintubation, episodes of hypoxemia, and exacerbation of the underlying disease, like a patient with COPD or asthma as an exacerbation. So this is what is defined as post-operative pulmonary complication. And when you go by this definition, and this is the systematic review done by Statna from Boston and for the American College of Physicians, and they figured out that if you use those defining criteria, these are around 6.8% across all types of surgeries. And with one pulmonary complication, there is an associated higher rate of mortality, ICU admission, and length of stay, which is why pulmonary complication, we kind of at times do not think about pulmonary complications, but pulmonary complications are, to me, as important as a cardiovascular complication, because you figure out the rates of cardiovascular complications are lower than what is being quoted in this slide. And that is essentially why you need to have a very good pulmonary evaluation, risk stratification, and necessarily, if necessary, optimization prior to surgery. We will focus on non-thoracic surgery for the next half an hour. All right. Okay. So if we can set up the poll questions now. So if you what you essentially what we will try and do is, if you look, we will give you these polls. Jyoti, can you set up the polls, please?
Yes, sir.
Okay. So you will have your polling things with you, the participant, whoever part of this. So we can start the poll. Which of the following is not a patient-related risk factor? I'll paraphrase it: which of the following is not a very significant patient-related risk factor for the development of postoperative pulmonary complications? Okay, if you have voted, we will close the polling in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. I think most of you would have voted. You can end the poll and we will go to the next poll. Okay, the next poll. We will come back. So let's just look at which pulmonary physiological change is not true during anesthesia and surgery. Vital capacity reduced by 50 to 60%, closing volume reduced by about 30%. Reductions in lung volumes are generally not seen with surgery on the extremities. Diaphragmatic dysfunction plays an important role in the changes. So please feel free, and this is complete anonymity. There is no marking on any one of you. So please feel free to put your votes on this. What we will do is we will, at the end of it, we will come back to these polling questions and then kind of sum up the entire thing. Okay, can we go to the next poll, end this poll and go to the next poll? We need to go to the next poll. And the next poll is you have to choose between these two. A 56-year-old male with a history of COPD is posted for a planned laparoscopic cholecystectomy. Okay, the person has mild dyspnea on exertion when you are seeing the person, has purulent sputum production, tells you, and when you auscultate, there is an audible wheeze. What will you do? You will increase the dose of the bronchodilators and steroids, start antibiotics, admit, proceed for surgery, or will you cancel the elective surgery, send the person for a pulmonology consult, wait for the resolution of sputum and disappearance of wheeze? So please let us know what you feel like doing. Again, we will come back to all these polling things at the end, and the reason why you are taking it through. So can we end the poll in 5, 4, 3, 2, and 1 and go to the next poll? Okay, so this is a 65-year-old female posted for thyroidectomy. She is a known asthmatic for more than 15 years. She's on inhaled steroids on a regular basis, occasional bronchodilators inhaled, has absolutely no functional impairment. She does her routine work. She is able to climb 2 flights of stairs. She is not breathless. She talks to you perfect. All right. Our other routine hematology biochemistry is normal. What would your plan for this lady be? whether it would be just inhale nebulization 30 minutes prior to surgery and proceed, or would you ask for a PFT and an ABG? If normal, then proceed. Start her on oral steroids and antibiotics and wait for 5 days and then take her up for thyroidectomy? Or would you refer her to a pulmonologist and then take her up, proceed subject to the clearance from the pulmonology consultant? What would you do on this scenario? So just feel free to put your vote into whatever you feel is the most appropriate for this. And again, if you are done your voting, I think most of you would have done your voting by this time. We'll close the voting in 5, 4, 3, 2, 1. Okay, and we'll go to the last poll. Jyoti, if you can reset and put that last poll. So this is a 66-year-old male with the type 2 diabetes, hypertensive, and hypothyroid. All of them are reasonably well controlled and is posted for hemicolectomy for CA colon. He gives history of difficult airway during a previous gallbladder surgery, which happened some 6 years back. Hemoglobin is 10.2, glycosylated hemoglobin is 5.9. The routine biochemistry and hematology otherwise are normal. So you want to do a further evaluation. So if you have to do one further evaluation, which will you choose? Would it be stop bank questionnaire? Would it be pulmonary function test? Would you do a CPET, or would you do a polysomnography? So which is the thing that you would want to do in this 66-year-old? And again, as I said, we will come back to all these at the end, provided you are awake when we finish. Okay, I think we can close the poll in 5, 4, 3, 2, 1. Okay, so we'll come back to the polls at the very end. Till then, again, as I said, just keep chatting, and we'll go through this. So we'll first deal about perioperative pulmonary physiology. If you look at the perioperative pulmonary physiology, it is essentially the development of postoperative complications are extension of the derangement of the pulmonary physiology, which is mostly of the restrictive type, like reduced lung volumes, diaphragmatic dysfunction takes place, reduction of the FRC, microatelectasis, loss of sighing breaths, and depression of the respiratory drive, inhibition of cough, and impairment of mucociliary clearance. And the last two essentially is because more not essentially mechanical causes, but due to the effect of drugs during the anesthetic course. Reduced lung volume, reduction of FRC typically happens more in thoracic and upper abdominal surgeries. The vital capacity reduces by 50 to 60%. The FRC reduces by 30%. And this reduction in lung volume, FRC, microatelectasis, loss of sighing breaths is mainly due to diaphragmatic dysfunction. Now, whether it is compression or whether this is flaccid paralysis or the abdominal contents going up due to the positioning or the institution of positive pressure ventilation, all these things. Along with this, postoperative pain, which is extension into the postoperative period, also could be a reason for all these which are mentioned in the left-hand side. FRC, we figured out, will go lower than the closing volumes. Once FRC goes lower than the closing volumes, you will have leads to microatelectasis, and atelectasis will contribute to the development of pneumonia and the VQ mismatching. Atelectasis is essentially what is happening is lungs which are well perfused, areas of the lungs which are well perfused but not ventilated, and this leads to impairment of gas exchange, and consequence is hypoxemia. And as you remember from the definition, hypoxemia is a definite postoperative pulmonary complication. Depression of the respiratory drive, as I mentioned earlier, is an effect of the anesthetic agents as well as opioids that you use in the postoperative period. So those are the pulmonary physiology that goes wrong. And what are the patient-related risk factors that has been studied and may not essentially be the reasons which are all important, like I think in Orwell's Animal Farm, some risk factors are more important than the others. So the patient-related risk factors are age, presence of COPD, asthma, smoking, general health status, obstructive sleep apnea, pulmonary hypertension, heart failure, upper respiratory tract infection, metabolic and nutritional factors. We'll quickly go through how each of these risk factors are important. If you look at age, it is has an independent effect on comorbidities after adjusting the other confounding factors. A age greater than 50, which makes me also kind of having an increased risk, is a predictor of increased risk. But as you see from this slide, as the age increases, the risk factor increases. So with every decade, the risk factor is increasing kind of in a not in an arithmetic fraction progression, but a little higher than that. So somebody above 80, the odds ratio is around 5.63 to somebody below 50. What is important, and I'd stress on this slide, that just age being an independent risk factor, other risk factors taken away, makes a healthy older patient carry substantial risk of pulmonary complications after surgery. If you remember about risk evaluation about cardiovascular complication, age was not an independent identifiable factor which causes increased cardiovascular risk. But in pulmonary complications, postoperatively, age is an independent risk factor. COPD, all the database will tell you that a patient with COPD will have a higher incidence of pneumonia, increased incidence of prolonged ventilation, or a chance of reintubation. Even in lower extremity surgeries like in THR, the mortality or a 30-day readmission rate is higher in patients with COPD. But what do most guidelines tell you? That despite the increased risk, there is no prohibitive level of a pulmonary function, which is an absolute contraindication for surgery. And when you're looking at through all the risk factors, patient risk factors, you'll find that COPD, we get worried about it, but it is contributing less than age and heart failure for the incidence of postoperative pulmonary complications. So the take home is that you have to do this risk-benefit analysis. If the benefit of surgery is higher, then just having a COPD should not be a deterrent for surgery. And even patients with possibly bad COPDs, if the reason for surgery is compelling, it is possibly good to take this patient up for surgery if the benefit of surgery is significant. Now, what about asthma? Earlier on, and this is especially when we were doing residency, that people thought that asthma patients who are asthmatic have a significantly higher rate of pulmonary complications. If you look at data, which is for the last couple of decades, you'll find that there has been low link about worse outcomes if, and this is very important to note, if the asthma is well controlled. So if you have an asthmatic, but well controlled, there is no higher risk that this person will have than somebody who does not have an asthma. These are the patient-related risk factors. So if you is what the person tells you, how good the person is over the years. Is there any allergen or an atopy? What is the level of medication that is used? Is there any triggering factor which you can try and figure out and stop? What is the frequency of the use of short-acting beta bronchodilators, the beta-2 agonist therapy? Has the person undergone hospitalization or an emergency department visit in the recent past, possibly in the last 6 weeks or 3 months? Has there been any history of intubation with a severe attack in the past? What is the frequency and the most recent use of oral glucocorticoids, not the inhaled? And has the person had a recent upper respiratory tract infection or a sinus infection, cough or fever in the past? And if the person has had a baseline PFT done, what is the PFR and FEV1 from these reports and how they are doing? So this is, when you're looking at an asthma patient, these are things that you can look at and then decide on the course. And this is a classic thing which is given, not made by me. This is from GINA, the Global Initiative in Asthma. And they are looking at what is the nature of the symptoms, what is the severity of the symptoms, and what is the risk, which is basically what you looked at from the previous slides, is what are the risks that they have, anything that confers that thing, and what is the severity of the symptoms, and then take a decision what to do and also classify the risk. The risk, as we have identified, is bronchospasm and laryngospasm in asthmatic patients. But do they occur uniformly through all of them? It has been figured out that it is more likely to happen if they use asthma medications, and I think we missed it on this, which is possibly greater than 1, so 2 or more. With existing noted asthma symptoms, the patient says that he or she is breathless, little bit of activity makes the person breathless, some kind of an allergen makes the person breathless, etc., etc. And if the person has visited a medical facility for asthma treatment in the past 30 days. So that is, again, about bronchospasm and laryngospasm. As I said, infection. The timing of elective surgery for an asthmatic patient with an upper respiratory tract infection is difficult. It will depend upon the severity of the patient's asthma. If it has gone bad, I think this is very intuitive. If the person is wheezing and is not doing well, then you need to kind of optimize before taking. So that's a risk factor. The degree of asthma control and the implications of delay of surgery needs to be factored in there, because how long can you wait? If it is a kind of intermediate acuity or even high acuity, how long can you wait? Remember, airway hyperreactivity will last for 2 to 6 weeks after an urinary tract, upper respiratory tract infection. So be aware of that these patients might have a higher incidence of bronchospasm and laryngospasm. So well controlled, the risk is low. Poorly controlled, risk is high. I think the bottom line is an asthmatic patient should not be wheezing at the time of surgery. I think this can be a take-home message of how to identify a risk of asthma in the preoperative period. What about smoking? Cigarette smokers have increased risk. So all of you, some 100 of you who are still here, if you are a smoker, you have a higher risk. And smoking cessation, this is, I think we will go through this later on. When is it maximum beneficial, whether it is 4 weeks, 6 weeks, 8 weeks, 2 weeks, or at all it is beneficial. So longer period of smoking cessation is more effective. If the amount of cigarettes smoked has been more, the risks is more. Greater than 20 pack year, the risk is higher. And it also increases the risk which is procedure dependent. So cardiovascular or oncological procedures, the risks of cigarette smoking is higher than possibly in other surgeries. Obesity. What about obesity and postoperative pulmonary complications? We kind of intuitively think that there are certain physiological changes that happens during obesity: reduction in lung volumes, ventilation perfusion mismatch, relative hypoxemia. And we initially discussed that, well, these are the things which leads to an increased risk of postoperative pulmonary complications, an accentuation of these changes. But if you look through data, obesity has consistently been shown not to be an independent factor of incurring postoperative pulmonary complications. And one of the biggest data has been from the American College of Surgery for the National Surgical Quality Initiative. Pulmonary complications were no more common in obese adults who had a BMI of more than 30 kg per meter square than in the non-obese individuals between 18.5 to 24.9. So obesity per se is not an independent risk factor for postoperative pulmonary complications. However, if they have obesity hypoventilation syndrome, somebody with a BMI of more than 30, with a PCO2 of greater than 45, these persons will definitely have a higher chances of requiring postoperative CPAP or a positive airway pressure therapy in the postoperative period. If obesity is obstructive sleep apnea an independent risk factor? Yes, it is. The risk of postoperative pulmonary complications is 2 to 4 times higher. Desaturation, respiratory failure are the most common things that happens in patients with OSA, along with certain non-pulmonary complications like cardiovascular and delirium. And the invasiveness of the surgical procedure also contributes to the risk significantly. And the severity of OSA also affects the perioperative risk. And these are other things. Again, these are again something which is there in all standard textbooks: anesthetics, sedatives, analgesics, any airway manipulation, the supine position, all increases the risk that is associated with OSA. And therefore, should we do screening for OSA preoperatively? Many in the world today are saying that OSA screening should be part of standard pre-anesthetic evaluation, and I am a great believer in that. And if you have to use certain screening questionnaires for this, taking the history and doing the physical examination, so that you can identify a known OSA and figure out how is the risk of OSA, how high is the risk, so that you have enough time prior to surgery to do any necessary intervention and implementation of precautions in the intraoperative and the postoperative period, so that you can reduce the risk of complications. So, whom to screen? Possibly all preoperative questionnaires, definitely those who have a BMI of above 35. But if you have a patient who is hypertensive with a diabetic, uncontrolled hypothyroidism with a history of stroke or a history of heart failure, I think OSA screening should be mandatory. Any history of difficult intubation for upper airway and a predictor of difficult intubation from your examination should undergo OSA screening. So how is the screening questionnaire done? It is the most popular is by which has been given from the Toronto General Hospital, Chung, and that is the stop bank questionnaire. Do they snore? The person is tired? Is there any observed incidents of stopped breathing? What is the blood pressure, high or low? Is the person hypertensive? What is the BMI more than 35? Is the age more than 50? Is the neck circumference large, 45? And is the person male or female? So that is the stop bank questionnaire. And if the answer to the questionnaire is 2 or 4, and a male gender, there is mild risk. It's high risk if the answer is between the score is less than 2, it is low risk. Intermediate risk is between 3 to 4, and any score above 5 is a high risk. And even in intermediate risk, if you can see that if the serum bicarbonates levels are higher, it increases the risk further. So what is now, this is something that was not well documented, but now people are saying that if the score is around 3 to 4, the serum bicarbs are higher, that person should be going into the high risk category. So that is about stop bang. You have other questionnaire systems like the Berlin. Let's skip that. Let's come to the other things. Pulmonary hypertension, I think this is very intuitive. It will definitely increase the complication risk, and the commonest complications would be lead from severe hypoxemia, can lead to circulatory collapse, and this happens irrespective of the underlying pathology, whether it is primary pulmonary hypertension or due to valvular reasons or whatever. And the list of things which in like an RAP more than 7, right ventricular hypertrophy, a low 6-minute walk distance, history of pulmonary embolism, use of vasopressors, or a major surgery increases. Along with it, the therapy for pulmonary hypertension, like they would be on anticoagulants, would risk the incidence of post-surgical bleeding as well. And there's a classification of the grading, which is just like the NYAHA classification for breathlessness and the CCS for angina, the same 1, 2, 3, 4. What about heart failure? I think just concentrate on this slide. The risk of pulmonary complication from heart failure is more than that from COPD. I think while I talked about COPD, I mentioned this, I'm mentioning it again. The odds ratio, pulmonary complications from heart failure is 2.9, whereas from COPD, it is 2.3. So be aware or think about heart failure. Keep it in mind. Upper respiratory tract infections. This, unfortunately, and I really don't know why we do not have sufficient data about this. And all the data you get is from children undergoing surgery. And in the recent the data that you get from children is that upper respiratory infection will possibly not lead to significant postoperative complication. But the guidelines, and this comes from possibly from India. This was published in 2005, that it is possibly prudent to defer elective surgery if there is an active upper respiratory infection. Patient-related risk factor about metabolic and nutritional factors. Serum albumin less than 3 is an independent risk factor, and it pays possibly if you've identified this, if you can correct, if it's correctable, it is wise to do that. And other thing is very intuitive. Functional dependence, impaired sensorium, all increase pulmonary risk. What are the procedure-related risk factors? The surgical site, duration of surgery, the type of anesthesia, kind of what neuromuscular blocks you are using, and if there is emergency surgery. The surgical site is the most important factor. The closer the surgery is towards the diaphragm, the higher is the incidence of postoperative pulmonary complications, which is why thoracic and upper abdominal surgeries leads to higher incidence of postoperative pulmonary complications. Head and neck surgery and neurosurgery are also quite important in developing surgical postoperative infection. Duration of surgery is important. Any surgery greater than 3 hours, every hour increases the risk by around 20%. So if there is, in your risk assessment, this person fits into a high risk category, you have to think about a less ambitious procedure on that person. Conflicting data about general anesthesia and regional anesthesia. Overall, it appears that general anesthesia leads to a higher risk of clinically important pulmonary complication than epidural or spinal, and obviously blocks are even better. And this is again from the NSQ data. You'll find that in regional, but I tried to look into their write-up. It was not adjusted for the types of surgery that was happening. Residual neuromuscular blockade can lead to diaphragmatic dysfunction, mucociliary clearance, hyperventilation, and therefore increased postoperative pulmonary complication. Very, very intuitive. And therefore, if you have used long-acting muscle relaxants, the more chances that you will develop PPC in those patients. So preoperative risk assessment is based upon clinical evaluation and by subject to tests, which I think Dr. Polash took off. A PFT gas exchange evaluation like ambulatory oximetry, chest radiographs, and CPET will not waste much of a time. But about clinical evaluation, you figured out that heart failure is very important, chronic lung disease is important, asthma is important. What you are looking at is exercise tolerance, unexplained dyspnea, or do they have cough, and should they need consideration. And it's just like the ACC-AHA. If irrespective of the surgery, this needs to be looked in, then they should be optimized prior to surgery. Questioning all patients prior to surgery about symptoms of OSA should come into the clinical evaluation, the stop bank questionnaire. Physical examination, look at what is happening to the obstructive lung disease, what is the breath sounds like, is there a wheeze, rhonchi, is there a prolonged expiratory phase? If it is definitely a wheeze, the person needs to be optimized before an elective surgery. So PFT, I think Polash took on this. I will not add that it does not add to the anything above what you established through your clinical assessment. So for a routine surgery, for a routine non-thoracic surgery and certain grades of upper abdominal surgery, it actually would not possibly give you much benefit. And it should not be used as a primary factor to deny surgery. I think this should be one of the take-home messages from about PFT. These are the kind of things. This is mainly from thoracic and also upper abdominal. So these will be patients with increased risk and FEV1 of less than 70% and an FEV1 not the percentage predicted, but the absolute value of less than 1 liter. Oxygenation and hypercapnia, again, measurement of the SpO2 is of great value, irrespective of the degree of surgery, duration of surgery. Should we do an ABG in most of our patients? It can only be useful if you feel that the resting SpO2 is less than 93%, has an abnormal serum bicarbonate, and if from the PFTs, the absolute FEV1 is less than 1 liter. Otherwise, ABG as a routine estimation of preoperative risk is not needed. Chest X-ray, I think we went through this elaborately. We will not go through this. We'll just wait, take a little time on the 6-minute shuffle walk test or the 6-minute walk test, since I think you will not be able to do an elaborate lab-based CPET, and this is something which is good to estimate what is their functional status. They are asked to walk for 6 minutes, and you kind of find out what is the distance they have walked, and has there been any fall in saturation? Has there been any change in heart rate and blood pressure during the procedure? And what has come out very well from this 6-minute walk test techniques and the challenges of this is, prior to oncosurgery, it has been demonstrated that if they can do, and we'll talk about this, certain amount of preoperative exercises, and you increase their ability to do the 6-minute walk test, they fare much better in the postoperative period. So estimating postoperative pulmonary risk, you use certain risk prediction tools, and this gives you an objective idea, and then based on that you can have certain risk reduction interventions. So what are the risk prediction tools? These are available on the net. Please have a look at it. The ARISCAT tool by Canet from, again, Harvard Medical School is possibly the easiest to use, and I find it pretty useful. It's free, it's online, you can use it. Then you have the Gupta indicators and the Arazula index. This is how the ARISCAT risk index looks like. These are the parameters. And I'll just take you, this is a snapshot of the website of ARISCAT. Canet is the name of the person who devised it. So you have age, you have to you have to just click on it, preoperative oxygen saturation, click on it, are there any other clinical risk factors? Click on it. Surgical incision, duration of surgery. You will get a total points based upon these, and then you can then have patients on these kind of criteria. I'll just take you through one of this. Suppose you have a person who is less than 50-year-old, whose room air saturation is more than 96%, does not have respiratory infection, does not have anemia. It's a planned surgery. It's an upper abdominal, say it's a laparoscopic cholecystectomy, which is going to take less than 2 hours. The total score is 15, and therefore he has between 0 to 25. It's a low risk of developing postoperative pulmonary complication. I'll just change it. Say it's between 51 to 80. The saturation is lower, 91 to 95. He is anemic, hemoglobin of less than 5. The same type of surgery. You look at the total score becomes 37, becomes moderate intermediate risk. The risk of postoperative pulmonary complications is 13.3%. This is objective. It is easier. It is easier for you to understand. It's easier for you to explain it to the patient or the patient relatives, and also to the surgeons. The same thing, if I also add respiratory infection in this person, saturation which is lower than 90%, same surgery, you find that the criterion score becomes 70, a very high risk of developing postoperative pulmonary complication, as high as 42%. I think this is a very useful score, very simple. It's available on net free. Please feel free to use it. Just remember the name Ariscat Canet, write it down. You can use it from tomorrow. These are the other risk indicators. I'll not bore you through this. It's again available. You can just guide through this. All the Gupta one is similar, but I find it a little more difficult to use. I find the Ariscat much easier to use. And from this, you essentially develop the algorithm. So from it, careful history and physical examination. This is what you do first. Does the patient have is the person undergoing a resective lung surgery? We'll not talk about this. He has complications. Then what are the complications? It could be, these are the ones that we discussed: COPD, asthma, poor general condition, heart failure, obstructive sleep apnea, pulmonary hypertension, or the person does not have. Then you proceed for surgery. And if it is positive, you had any of these things that we discussed, then think about testing: chest x-ray, PFT, CPETs. And if the normal test, you have got your risk factors calculated from the Ariscat index, designate it as moderate risk, and then take appropriate steps and go ahead with surgery. If it is high risk, the ones that are above 42%, then reconsider the indication for surgery. Think of a possibly a lesser invasive surgery, because you have a very high chance of developing a significant postoperative pulmonary complication. So I think this is an easy algorithm to incorporate in your clinical practice. So the definite risk factors are upper abdominal surgeries, thoracic surgeries, emergency surgeries, an age above 65, surgery lasting greater than 3 hours. It's just a recap of what I've already said. Poor general health status, an ASA classification above 2, somebody with heart failure, albumin less than 3, COPD, cigarette use, intraoperative long-acting muscular blocker, which is most likely not going to happen, functional dependence. Probable risk factors are GA instead of regional, PCO2 baseline above 45, an abnormal chest X-ray, current respiratory tract, viral respiratory tract infection, and post-operative nasogastric tube placement. So what are the strategies, therefore, you have to reduce post-operative pulmonary complications? The strategies would be, again, is essentially we figured out the factors, try and do it. Smoking cessation, looking after COPD and asthma. If there is a flare-up of COPD asthma, definitely treat it. We'll come to this. Antibiotics, elective surgery has to be taken in, even if there is COPD or emergency surgery has to be taken in. Elective surgery, if respiratory infection is present in the presence of a COPD or an asthmatic patient, you need to delay, give them antibiotics. Preoperative oral care will come to this. And I think this is something which we don't think intuitively, and this is a huge amount of data coming on this. Initiating physical exercises, increasing their aerobic threshold, increasing their breathing exercises, inspiratory muscle training will improve their performance in the postoperative period. Smoking cessation. There is a definite benefit of smoking cessation. So now how long should the cessation happen is what is the kind of debate. It definitely improves wound healing and postoperative pulmonary recovery. And many people are of the opinion, based upon this Cochrane database systematic review, that greater than 8 weeks, it is very, very good. They do brilliant. Now, what came into as a kind of a spanner in the works was this data about CABG patients, which came out in the early 90s or mid 90s, that either you have the cessation before 8 months, before 8 weeks, or you don't have cessation. If you have in the intermediate, they're actually doing worse. So that made it like, if you have not stopped it, then don't smoke it. But what is the current recommendations on it? The current recommendations on it is you need to quit, because between early and late quitters, each week of cessation increase the beneficial effects of cessation. And both the pulmonary complications and total complications were less in people who had stopped smoking than who were currently smoking. Yes, it is very beneficial when it is above 8 weeks. It is also beneficial when it is between 4 to 6 weeks. It is less beneficial when it is less than 2 weeks, but still beneficial than those who have continued smoking. So what is our recommendation? We say that since there is no evidence of harm related to short duration cigarette abstinence, advise all patients anticipating elective surgery to quit smoking as soon as possible, regardless of the anticipated date of surgery. If time allows, then 8 weeks time is possibly the best. I don't know whether you can actually implement this. What about COPD people? COPD should be aggressively treated in order to achieve the best possible baseline level of function. The specifics of treatment is taken from the global initiative on obstructive lung disease, the GOLD, ABCD. What is the kind of symptoms? How much is the risk? And if it is very symptomatic and then going in for high risk, it's the highest amount of intervention. And this again, it takes about surgery, irrespective of whether surgery is going to happen or not. You will essentially intervene. So exacerbation of COPD, elective surgery should be delayed till they go back to baseline. This is, I think, the bottom line. Steroids, preoperative empiric dose. This, I think, it becomes kind of a confusing thing. I think it is very simple. If the person has been taking more than 20 milligram of prednisolone or its equivalent, which is 16 milligram of methylprednisolone, 2 milligram of dexamethasone, or 80 milligram of hydrocortisone per day, and if they have been taking this for more than 3 weeks in the last 6 months, it is likely to cause suppression of the hypothalamic pituitary adrenal axis. And in this group of patients, it is recommended that you use an empiric dose of glucocorticoids before induction of anesthesia. So I think this should clear all the confusion about who should receive preoperative empiric dose. And this is COPD as well as in asthma. And how much is this empiric dose? If it is a minor procedure, just give the morning dose that the person is receiving. If it is intermediate procedure like a joint replacement, total revascularization of the extremities, give 50 milligram of hydrocortisone IV before induction, and repeat it within after 25 milligram after 8 hours for 24 hours. If it's a major surgery, thoracic surgery, esophageal gastrectomy, major GI surgeries, cardiac surgery, morning dose is given. Then you give 100 milligram of intravenous hydrocortisone prior to induction of anesthesia. And Also 50 milligram every 8 hours for the first 4 hours. Okay, what about asthma? I think we talked about it. If it is poorly controlled asthma, it's a risk, so they should be evaluated. If it is well controlled, you go, because they do not confer any additional risk, go ahead with the surgery. And not well controlled would possibly be candidates for systemic glucocorticoids. And again, this is again from the GINA website. So again, looking at their symptoms, a lot about it is personal assessment, and a lot about is about what makes it worse. And if it is there, think about, then decide whether it is uncontrolled, poorly controlled, or well controlled, and proceed accordingly. So the pre-op strategy, I think one clear guidelines is they should be free of wheezing before they come in for surgery. And if they require endotracheal intubation, they should get inhaled rapid-acting beta agonist, bronchodilator, 30 minutes prior to intubation. I think this is the take-home about asthma, and it can be continued in the intraoperative period as well as in the postoperative period. Should they receive preoperative steroids? Unless it is brittle asthma, if it is well controlled, you do not have to use preoperative steroids for just to decrease the incidence of bronchospasm, laryngospasm. There is no evidence on that. Antibiotics, yes. If they have acute bronchitis, a flare of COPDs, bronchiectasis, clinically apparent lower respiratory tract infection with a purulent sputum, they have to receive antibiotics. And all these have to be resolved prior to an elective surgery. Elective surgery cannot happen with these things on board. And just because a patient is COPD stable or an asthma stable, there is no role of preoperative antibiotics. So about asthma respiratory, I think we talked about this in the prior discussions, and this is based upon those child data. So which is, and I don't know why this has not been looked into, but till you have anything, if there is an active upper respiratory tract infection, elective surgery which can wait should wait. Oral care, I think this is about chlorhexidine, hugely beneficial in cardiac surgery, and I don't know whether Dr. Shubhabrata Pala, our first student, is there. This was one of his thesis topic, and we found, according to the world data as well, that it is hugely beneficial. Can be useful also in non-cardiac thoracic and abdominal surgery. Oral care is about brushing, about removing plaques and everything, which has improved. And this is something which has, in the last 5 years or 6 years, mainly from oncosurgery, aerobic exercises, breathing exercises, inspiratory muscle training can reduce postoperative pulmonary complication. And so teach them about coughing, teach them about incentive spirometry, voluntary deep breaths, because you cannot teach them in the postoperative period. So, and they have to do this in the postoperative period. And these lung expansion maneuvers can reduce the incidence of postoperative pulmonary complications. Intra-op strategies, I think we will not look into this much. Shorter procedures are better, neuraxial procedures are better, regional procedures, they will be better than general anesthesia. Less invasive procedures are possibly beneficial. You will not use a long-acting today. And about PA catheter, I don't think anybody uses it anymore. Post-operative thing is deep breathing exercises. Pain control is a big issue, and if pain control is good, all those restrictive physiology that sets in can be less. Post-operative is, again, some people who would benefit by a positive airway pressure, they should be done. And I think one of the single contributor to postoperative pulmonary complication is the presence of an esogastric tube. In ERAS, we mentioned that take out those drains and tube as quickly as you can. So before we conclude, and this is again the take-home messages, is which of the following is not a hugely significant factor related to the development of postoperative pulmonary complication. Most of you thought it is 50% voted for albumin, but if you look at it and you went through this, obesity is individually not a contributing factor, and there is no reason that an obese person, if the surgery is indicated, can go in for that surgery. So obesity is not not true about the physiological changes during anesthesia surgery. I think most of you got this right. Closing volume is not changed. The only thing that closing volume changes is age, for possibly, and certain postures. So it is not changed. I think again, I think 56-year-old COPD with dyspnea on exertion, purulent sputum production, audible wheeze. What will you do? I think all of you nearly got it. I think this is very, very intuitive. You will cancel surgery. These have to be stabilized before elective surgery. You can't be taking in somebody who would otherwise definitely need therapy for this. Again, asthmatic, stable, controlled asthma on occasional bronchodilators, no functional impairment. What will you do? I think 60% of you are in concurrence with what I think, which would be inhaled nebulization 30 minutes prior to surgery. No need of an APFT or an ABG. Definitely, you're not going to start antibiotics or steroids. And even pulmonology consult, you have evaluated stable. I think you proceed for surgery anyway. 66-year-old. I think this is something that I was looking at. What will you do? Type 2 diabetes, hypertensive, hypothyroid, with a previous history of difficult airway. Otherwise, biochemical parameters looking good. I think if you have heard through this, you would possibly look at what I was alluding to, is that they should go in through a stop bank questionnaire and not PFT, CPAT, or polysomnography. So stop bank should be a part of your pre-anesthetic evaluation for most of your patients. So that is the take home. The take home is, if it is, I think it is very, very clinical. If they have symptoms which needs to be treated, it has to be treated before they're taken up. There are certain things like heart failure, poorly controlled asthma, age, COPD, which are bad. Obstructive sleep apnea per se is bad. And this type of surgery closer to diaphragm is bad. Duration of surgery is bad. I think among the things that we think is among the risk assessment tool, the screening procedure for OSA is something that we possibly intuitively do not think of, but should be taking it up. And thank you for a patient hearing. And I exceeded my time limit by another 10-15 minutes than what I thought I would. So thank you for still being there. It's amazing that we had something close to 150 or 160 people. So if any meeting or any conference, when this happens, it's a full hall, and the conference organizers think that it is brilliant. We have done so well. But that's the beauty of this web-based things. You still have people. I think you can be munching your dinner or sipping at your wine or whatever you have in your glass. I have just glass of water. And my wife is kind of scared that if I have a glass bottle of glass, then it can break. So that's why the stainless steel one. Anyway, so are there any questions?
So we have a question from Dr. Tripathi from the previous session. How diabetic autoneuropathy can influence CPET?
Paula,
So if we have Dr. Polash, or you can also enlighten.
I really don't know. I'll have to look up. Dr. Tripathi, I really don't know. I'll have to look up.
So we can.
Uh, Dr. Niladri Mukherjee, do we need to replace IV steroids periop if a patient takes steroid inhaler? I think I answered this. You go through that. Anyone who has been taking more equivalent of 20 milligram of prednisolone, if you feel that inhaled bronchodilator uh, kind of, it's very unlikely that it will be more than 20 milligram. It's about oral. So with inhaled, you possibly would not know. But if there have been an oral steroid therapy for 3 weeks and more in the last 6 months, definitely you need to do a perioperative empiric steroid therapy after just prior to induction. How much maximum duration should be allowed for pelvic laparoscopic surgeries? So what do? Because it is more than 3 hours, and you say that you open it up. I think you cannot actually do that. I think it should be a mutually agreed decision between you, the gynecologist, the patient, about everything. That if you figure out that it is taking longer time, and after some time, what I kind of look at is there been a definite progress every 15-minute kind of intervals? If there has been no progress happening in the last two 15-minute intervals, then it is time that you think of doing something else like opening up. So I won't put a kind of a thing on that 3 hours ho gaya matlab band kar do, khol do, but you take a judgmental call as it is happening. And if it is a respiratory cripple with a steep Trendelenburg, that it is going to add to the risk. It's not a great idea to do it. How much maximum should, I think that is about it.
So we have a question from Dr. Sanyal. So we have a question from Dr. Ramapati Sanyal. What all are the objective criteria of well-controlled asthma?
Thank you, Ramapati, for being there. I think it's just go by the GINA criteria, the global initiative in asthma. I think they have made it. It's about the most important thing they look at it is the patient's self-assessment. That how much are they symptom free from what they were at their best and what they were at their worst. So that is one. The second is what has been the type of therapy that they are needing to be what they are. What has been the use of the bronchodilators, beta agonists, or antimuscarinic agents, and the IV, the inhaled steroids. I will not be able to tell you exactly the numbers, but you go by the GINA criteria. They have it over there. Again, have they been on chronic oral corticosteroid therapy? It is possibly that means they're moderately controlled, not very well controlled. Have they needed to be hospitalized, or have they needed to come into the hospital and needed nebulization and then gone back? What has been the incidence in the last 6 months? Again, if it has happened more than once, it is not well controlled. And if they have been subjected to a pulmonary function test, then how close are they to their baseline, or how close are they to a PFR of around 80% of predicted? If they are very far away from PFR of 80%, it is again not well controlled. So those are the kind of objective criterias. And if I don't exactly remember, but the GINA website also gives you the attack scores, ATAQ, about how to do the preoperative, and this is not necessarily about just preoperative assessment. It is about an individual assessment of a person with asthma with therapy as to how they're doing. So if you're looking at objective test criteria, I think the pulmonary function test, the PFR and how close is it to 80% is important. And from the history, it will come down to the number of admissions in the last 6 months, number of acute attacks in the last 6 months. Then is just look at it, the data about if it is inhaled, what has been the doses of inhaled. Again, objective, if they have needed long-term oral corticosteroid therapy will be objective. And in clinical evaluation, it is the presence or the absence of wheeze. Anybody with any comment?
Dr. Anirban Das has
Dr.
Anirban Das has a question. In preoperative optimization, which one is better, MDI or nebulization? Do nebulization increase the risk of postoperative pneumonia?
If you're looking at optimization in the sense that you're talking about this person is not well controlled and therefore would need therapy for asthma before the person goes in for elective surgery. Now, it all depend. It will depend upon the the kind of severity of the exacerbation of asthma or COPD. If it is so severe, a metered dose inhaler will not work because the person does not have the ability to send this thing to the area where it is supposed to work. Then you will have to go in for the standard nebulization techniques. Yes, nebulization techniques, just like any intervention, does not come free, will come with the thing. But again, if you have good infection control policies in your hospital or in institution, you should be able to take care of that. I think
another question from Dr. Nitai Datta. Why CPET? Another question from Dr. Nitai Datta. Why CPET is not popular among us due to non-availability or cost per patient?
I think the elaborate CPET, wherein you look at the VO2 max and the anaerobic threshold, is it's even if you look at it in the West, you'll not find it in all community hospital or the district hospitals in the UK or even in the US. It's more of an academic thing that is still there. Or if it is in if that place is hugely into sports medicine, that you find more of the CPET labs coming in, because it's that's how they get the CPET lab going, because they look at sportsmen and how their endurance is building up. I think cost will be a factor, but I think what you can possibly use, which we use hugely in our institution, is the surrogate for elaborate CPET, which is the 6-minute walk test. So 6-minute walk test is simple. We used to first do it in the ward, but then my friend Dr. Suresh and we kind of evolved this. So, and that is what, based upon what I discussed, is you start a buzzer for 6 minutes. You then measure. They should be in a comfortable shoe and an attire. Walk. How much is the distance they walk? At least do they walk more than 450 meters? At least around 500 meters. Look at their baseline saturation, and if they have an ambulatory pulse oximetry, you can monitor it. Is there a fall of more than 4% during the 6 minute, or has there been an increase in heart rate by around 15 to 20% from what the baseline is? So, and if while doing the 6 minute, if they kind of become breathless or they find giddy, you stop the test, and that means their exercise performance is low. But what is not only do you figure out that these are persons who will not do well, but these are persons by which physical exercises like strength building, if you can increase their albumin levels, they actually benefit a lot by improving their the aerobic capacity or the ability to do more of aerobic exercises. I think, Jyoti, you can close this by your concluding remarks. Thank you, everybody, for being there. Thank you, Polash, for taking the trouble of doing such 3 hugely very beautiful, very informative sessions. Thank you very much.
So thank you everyone for joining us. Thank you, Dr. Sengupta, Dr. Kumar, for your sessions. And I would request all of you, since this is a new initiative we have started, your feedbacks are very important to us. So kindly share your feedbacks. After this session ends, you will get a mail, individual mail. So you just click onto the link in the mail and share your feedback. And once you share your feedback, this is just customary, you will get an e-certificate signed by Dr. Sengupta and Dr. Kumar. And within 24 hours, like maybe tomorrow in the evening, late evening, you will get a link through which you can visit edu.hcpforum.com, where you can revisit all the lectures of Dr. Sengupta and team. So thank you everyone for participating. Thank you faculty, and have a good night. Bye-bye.
Good night.